Good day, my name is Marq Walker and I'm the Program Manager for HITArkansas. Today I'll be presenting information on leveraging meaningful use for healthy patients and healthy practices. Most of you are already working with HITArkansas, so I'll only touch briefly on the content of some of these first few slides. The REC sprang into existence 3 years ago as a result of the American Recovery and Reinvestment Act. The short-term focus of our grant is to assist eligible professionals, or EPs, with achieving the meaningful use of their ONC-certified EHRs so that they can earn incentives. The long-term effects of becoming meaningful users are related to supporting the design of sustainable public health policies, as you will see presented today. This is the scope of the Regional Extension Services. As our team of specialists enter practices, we assess their status and just take off from that point on guiding them through the process of achieving meaningful use. There are 2 programs under which eligible professionals can participate, the Medicaid and the Medicare incentive programs. It's important to note that for Medicare eligible professionals, 2012 is the last year to begin participation and receive the maximum incentive of $44,000, which is paid out over 5 years. For EPs who delay achievement of meaningful use until next year, 2013, the maximum drops to $39,000, paid out over 4 years. And for those who delay until 2014, the maximum drops to $24,000, which is paid out over 3 years. Now, these are the different eligible professionals that qualify under the Medicaid and the Medicare EHR incentive programs. You'll note that under Medicaid, nurse practitioners, PAs, and certified nurse midwives only qualify to participate under the Medicaid EHR incentive program, where podiatrists, optometrists, and chiropractors only qualify to participate in the Medicare EHR incentive program. And in addition to working with eligible professionals, our grant covers assisting critical access hospitals with achievement of meaningful use. These are the requirements that Medicare eligible professionals must meet in order to achieve Stage 1 of meaningful use. Providers are only required to meet the Stage 1 requirements for their first 2 meaningful use reporting periods. These are the general requirements for EPs who are participating in the Medicaid EHR incentive program. There are 6 payment years, and in payment year 1 there's no requirement to achieve meaningful use. That must be achieved only in payment years 2 through 6. And here are a few additional requirements for eligible professionals who practice at multiple locations or who practice predominantly at federally qualified health centers or rural health clinics. The focus of our grant has been to work with priority primary care providers, PPCPs, but we have been reaching out to specialists. We're currently assisting specialists in the areas of ophthalmology, optometry, behavioral health, general surgery, plastic surgery, cardiology, oncology, dentistry, orthopedics, and more. They are eligible for the same incentives as priority primary care physicians, and they must meet the same requirements. We do render the same scope of services to specialists. One difference between a primary care professional, eligible provider, and a specialist is that specialists are more likely to claim certain exclusions based on the scope of their practices. And then some specialists need assistance with the selection of clinical quality measures. We deliver complete services all the way through to attestation. As of August, CMS had paid more than $6.9 billion to eligible providers in the Medicare and Medicaid EHR incentive programs nationwide. And in Arkansas, over $81 million has been paid to eligible providers and hospitals participating in the EHR incentive programs. I mentioned earlier that 2012 is the last year for Medicare EPs to begin participation and earn the maximum incentive of $44,000. So if you are a Medicare EP and you've not begun your 90-day meaningful use period as of October 3rd, your opportunity to earn the maximum has likely passed you by. But I don't want you to get discouraged. If you do achieve meaningful use in 2013, your maximum drops to just $39,000. It's when you wait until 2014 to participate that your maximum drops really significantly to $24,000 paid out over 3 years. The other thing to note is that part of our grant subsidy has been fulfilled, and the remaining part of our grant, which subsidizes our services to priority primary care providers, ends in September of 2013. So if a provider has not even made a decision about a vendor, their contract may sunset before September and before they achieve meaningful use, and they may be paying retail price for our services. So knowing how much providers need these incentives to help update their health IT systems, we do all that we can to ensure that they don't leave this money sitting on the table. So let's talk about meaningful use. Meaningful use is a means to an end, the end of which are the public policy goals of improving the quality, safety, and efficient delivery of health care, reducing health disparities among patient populations, encouraging patients and families to be engaged in their health care, and improving the way health care is coordinated as a patient moves from one health care setting to another, generally improving population and public health. In addition, because we're employing electronic health records, we want to ensure that electronic personal health information is private and secured from unauthorized access. I kind of like this grid. It demonstrates how the data that providers enter into their EHRs starts to lay the foundation for meeting these long-range public health objectives. And across the bottom is a nice little workflow that can be used as a guide to when during an encounter the data can be captured. We are currently in stage 1 of meaningful use. CMS has extended the length of stage 1 such that all eligible professionals, regardless when they begin participation, have to meet only the stage 1 meaningful use objectives in their first 2 meaningful use reporting periods. Stage 2 does not become effective until 2014 at the very earliest. These are the data elements which must be reported during the stage 1 of meaningful use, and I'm not going to go into these in detail. The list of meaningful use objectives and the clinical quality measures are downloadable at our website, which will be listed at the end of this presentation. There are changes to stage 1 of meaningful use that become effective at the beginning of 2013, which you really need to take note of. Eligible professionals will no longer be permitted to count an exclusion toward the minimum of 5 menu objectives on which they must report if there are other menu objectives which they can select. Now, our team has not been allowing the EPs that we work with to do this because there was already an FAQ which addressed this. However, CMS made a formal announcement about this. When it comes to computerized physician order entry, CPOE, a new alternate measure has been added. The current measure is based on the number of unique patients with a medication order in their medication list that was entered using CPOE. But the new alternate measure is based on the total number of medication orders instead of unique patients that was created during the EHR reporting period. Either measure may be selected for this objective in stage 1 beginning in 2013. This new measure will be required in stage 2. When it comes to e-prescribing, there's a new exclusion added for providers who are not within a 10-mile radius of a pharmacy that accepts electronic prescriptions. For vital signs, The current measure specifies that vital signs must be recorded for more than 50% of all unique patients ages 2 and over. The new measure amends the age limit to recording blood pressure for patients ages 3 and over, and height and weight for patients of all ages. And there are 4 exclusions instead of just 1. These 4 exclusions may be claimed when either the eligible professional who sees no patients 3 years or older is excluded from recording the blood pressure, or when the EP believes that all 3 vitals of height, weight, and blood pressure have no relevance, or the EP believes that height and weight are relevant but blood pressure is not, so they may be excluded from recording blood pressure, or last, the EP believes that the blood pressure is relevant to the scope of practice but height and weight are not, so the EP is excluded from recording height and weight. The electronic exchange of key clinical information will no longer be required, but CMS is moving to a more robust requirement for health information exchange as a part of Stage 2. Reporting clinical quality measures will still be required. It's simply not being listed as a core objective because it's redundant. And then when it comes to public health reporting, EPs must submit a test even if it is not required by law or by practice. CMS has published a tip sheet for these changes, and I've included a link for that at the end of this presentation. In order to better align Stage 1 objectives with the new capabilities of certified EHR technology, CMS is replacing these 2 Stage 1 measures with a new objective and measure. The new EP objective is to provide patients with the ability to view online, to download and transmit their health information to a third party within 4 business days of the information being available to the EP. And the new measure is that more than 50% of all unique patients seen during the EHR reporting period meet that. So for this, the patient portal will be required. Stage 2 of meaningful use builds upon the progress made during Stage 1. Some Stage 1 objectives have been combined or separated or moved from the menu set to the core set becoming required, and some have even been eliminated. Many of the thresholds have been increased, and noteworthy is the fact that beginning in Stage 2, again, patients must be able to view, download, or transmit their ePHI to a third party, so it will require a patient portal, and some vendors charge extra for this functionality, so you should check with your vendor about planning for this. In addition, because all ONC certified EHRs will be required to meet the new 2014 certification requirements, eligible professionals will then have to upgrade their EHRs to the new 2014 certified versions. And CMS has determined that to facilitate these upgrades, the required meaningful use reporting period for 2014 for all EPs will be just 3 months. Medicare EPs will select a calendar quarter, and Medicaid EPs may select any 3 consecutive months. HITArkansas will be hosting a webinar about Stage 2 with details to follow. These are some of the healthcare initiatives which have already been introduced, some of which are on the horizon, and all of which are supported by the meaningful use of EHRs. Phase 1 of the Arkansas Healthcare Payment Improvement Initiative introduced only 5 episodes of care. In 6 months or so, however, there will be a number of additional episodes of care not identified yet, for which providers will be held accountable. Providers will need to be able to coordinate and track referrals for episodes of care and to monitor them internally, and EHRs will help make these processes possible to manage. Accountable care organizations are groups of healthcare providers who deliver coordinated care and manage chronic disease based on benchmarks and quality measures developed by CMS. When they produce cost savings, those monies are shared by the members. However, there is the risk as well. ACOs are not a major influence in Arkansas at this time. There's only one so far, but ACOs are on the radar to watch and to be aware of. The Comprehensive Primary Care Initiative is an example of how achieving meaningful use helped to position providers such that they could participate in an enhanced payment program. In this program, Medicaid, Medicare, Health Advantage, and Qual Choice are issuing additional payments to providers who are participating in the program, again providing incentives to providers to participate in innovative and transformative activities. Patient-centered medical homes are growing in influence both nationally and in our state. You can see how the public policy objectives of meaningful use align with the movement towards PCMHs. Meaningful use was designed to start the process of capturing data that is needed for public health infrastructure, and the meaningful use objectives align with public policy and other innovation programs. The former administrator of CMS, Don Berwick, stated that better performance is a matter of design. So your electronic health records are a vital part of designing improved performance and outcomes. So where's your practice in its innovative and transformative journey towards meaningful use? Have you AIU'd? Are you on track to achieve meaningful use? Or is your practice stalled? We find that there are a lot of bumps in the road to achieving meaningful use. Our staff walks into practices and finds practice issues which are all over the map. Some of them are due to bad habits which were formed at the beginning of AIU of the EHR, or they've implemented workflows based on misinformation about meaningful use which they've obtained from a variety of sources, or they find that change is difficult. There are also a lot of vendor issues. I think providers who are using EHRs find that the process of adopting, implementing, or upgrading is one that requires patience and persistence in dealing with their software vendors. And then there are meaningful use issues. Meaningful use objectives may not fit into the practice's current workflows, and many practices aren't even aware that they need to update their HIPAA policies if they have EHRs. Or the practice may be meeting its measures, suffers staff turnover, and finds that the person who is capturing data correctly or printing clinical summaries left, and the new person had not adopted that into their workflow. Overcoming barriers is what our team of implementation specialists excel at. On a daily basis, our team is on-site in practices helping them with their practice issues, and that often includes teleconferencing with CMS, Medicaid, or the Arkansas Incentive Payment Team, or with software vendors, leveraging our relationships with these partners to advocate for our providers and help them resolve their issues. Our regular monitoring of provider progress helps to make sure that the provider stays on track. And a very important piece of our work involves the high-tech compliant HIPAA security policies and procedures that we help practices develop. It's our purpose to assist eligible professionals to achieve meaningful use and earn incentives as our country moves toward outcome-driven health care. I hope we're working with all of you who are here today, and we want to assist you with making sure that your practice is ready to participate in healthcare innovation and enhanced payment programs. Some of you who are here today may have already attested to meaningful use, and you've been asking how the Regional Extension Center is going to continue to help you now that the contract with the REC has been fulfilled. HITArkansas is now offering subscription service for practices consisting of buckets of hours which may be used for ongoing meaningful use activities or the annual security risk analysis. In addition, we plan to add practice management and informatics services to the menu. We have a well-credentialed and talented team of consultants who are looking forward to continuing to work with Arkansas's providers in a variety of capacities. Before I close, I just want to re-emphasize a very important part of the work we do: protection of personal health information and EHRs. Whether or not you're working with the REC, I urge you to make sure that your practice has implemented the HIPAA information security policies required by the HITAC Act. The cost of noncompliance is very high, as you can see. If you need our help with this, you know how to get in touch with us. Meaningful Use is here to stay, and I hope you feel encouraged today in knowing that as healthcare transforms it into what is hoped will be an improved, sustainable model, that you have partners such as AFMC who considers your success in the process to be our success as well. Today, it's our pleasure to be working with over 1,325 providers in over 550 practice settings. As of August, 889 of our provider members have gone live on EHRs, and close to 300 have achieved meaningful use. On the hospital side, we're working with 16 critical access hospitals, 4 of which have adopted and implemented an EHR, and 4 of which have achieved meaningful use. For more details on the changes to Stage 1 that will take place in 2013 and 2014, I encourage you to visit the CMS website and download the tip sheet. Please call us with any questions that you have regarding any part of this presentation, and here's our contact information. Thank you.